I see it.
This is the this is the second of our sessions, our pitch sessions. We just started the semifinals for Fire Pitch 2021 today, and we're delighted to have you with us. And many of you have done this before, and it's great to see you again. And we so appreciate the time and expertise you share with the competing startups. Ignite was founded in 2017, as you heard in the video. I think that it's fair to say our most impactful program to date has been these mini accelerator programs that now reach across the world in terms of identifying women doing great work. When we started in 2017, we were looking at maybe a little, motivated by Shark Tank, and thinking we could host a Shark Tank that focuses on women-led digital health and med device companies. When you look at healthcare, there are women everywhere in healthcare. 80% of healthcare purchase decisions are made by women. They're 60 to 70% of the workforce. But yet, when you look at the leadership in healthcare organizations, 13% have women at the helm. And when you look at the amount of venture capital that goes to women, female entrepreneurs, it's barely 3%. At the highest in 2019, it was 2.9%. And with COVID and everything else, it dropped off. So this is our opportunity to really showcase the best of the best companies. This year, in 2017, we had 17, 18 applicants. This year we had 130 applicants and actually had 263 companies that were engaged in the platform to apply. So we're really getting an incredible list of women doing great work across the country. And we hope that the 6 you'll hear today will impress and inspire you and give you an example of the kind of talent that is out there. We can't do this by ourselves. We are very, very fortunate to be surrounded by partners who really power the mini accelerator. So the customer partners who represent the voice of customers for the startups that are selected, and the investor partners who represent the voice of investors for startups. Each startup in our program is matched with one from either column and from each column. And they spend 6 to 8 weeks with meetings and feedback and insights that help them to move their companies forward, but also help them to develop their pitches, refine their pitches for today. So I think you're in for a very good session. We also can't do this without sponsors. As you've heard, we are not for profit. And Cheryl Stavens and I and the team at Ignite can only do so much, but with the support from the TMC, J Labs, Accenture, JP Morgan, and you see the rest of the world-class organizations that have been supporting our efforts and being able to really focus and create this amazing ecosystem that supports female entrepreneurs. So with that, I've sort of set the stage for how we got here and the great partners we have and sponsors we have. I want to just bring your attention to how we make the cut for the finals event. Finals event will be will be in January 20th. We've moved it from November so that we can have a safe in-person event at the Texas Medical Center's Innovation Facility on January 20th. And we will have the votes from the judges determine the winners from each of our competing panels. So your votes today, judges, are helping to determine who will make it from this panel to the January 20th grand finale. But there's more. So if you look at the People's Choice Award, you see the link here, and Megan will share it, and it'll be shared widely through Whova, so that even as judges, you can go back and see the recordings of all the pitches of all 32 companies. And maybe there is another company out there that you think is deserving of being on stage at the grand finale in January. So please take some time, if you've got time, and take a look at the recordings. And for the people that are in the audience, you have an opportunity to influence who gets into finals. The voting for the People's Choice Award ends on Friday at 11:59 p.m. and that's 11:59 Houston time. So take a look and please participate. Would love to have you see more and more of these great companies. So now I'm going to turn it over to the moderator for this session, Anna Vu. Anna is an innovation analyst at TMC Innovation, where she evaluates market trends and supports digital health and medical device startups as they develop their innovative healthcare solutions. So she's very well versed in this environment, and TMC is an incredible partner and has been a great support to us. So with that, I'm going to turn it over to Anna, and I'm going to stop sharing. And Anna, it's all you.
Thanks, Aisha. Good afternoon, everyone, and welcome again to session 2 of the Ignite Fire Pitch 2021 semifinals. We've got 6 really exciting women-led healthcare companies. We've got a fantastic panel of judges, so this should be a great session. As Aisha mentioned, today's event would not be possible without our great sponsors. If you want to learn more about who they are, what they're doing, we have a sponsors page, or you can click directly on any of their logos throughout the event site. Each one of them really helps us make this event bigger and better each year. Special thanks to J&J and Texas Medical Center Innovation. They've been supporting us for so many years. Below this video window, you can find more information about the speakers and judges in this session, and the companies themselves were listed at the bottom of the page. Just a quick reminder about the format of this session. Each company is going to have 7 minutes to present, and then they're going to follow up with 8 minutes of Q&A from our judges. We'll have a short break in between to reset and let the judges submit their scores. I have my timer set, so we're going to get started. First up is Sigalit Marmestein with Baby Live Advice.
Hi, everyone. Let me get my PowerPoints on. Can you guys see my screen? So I'm the first. We'll see what all the technical issues. Is that working?
Yep, you're good.
Perfect. Excellent. So hi, everyone. My name is Sigi Marmestein. I'm the CEO and founder of Baby Live Advice. We are a company that virtually support birthing people from pregnancy to parenthood. A little bit about me. I'm a nurse practitioner with 25 years of clinical health experience, as well as 14 years as a telehealth consultant. I started 65 telehealth programs in the United States in the last 14 years with companies such as Kaiser, the VA, Adventist Health, and others. We spend about $100 million every year on maternal and newborn care, yet we are the deadliest country in the industrial world by which to have a child. Each year, an estimated 880 women, about 2 every day, die from complications related to pregnancy and childbirth. More than 52,000 women each year, 1 every 10 minutes, experience severe maternal morbidity, which may lead to health problems that are lifelong. These are infections, pelvic floor dysfunction, depression, bleeding, NICU admissions, and others. Those are actually worth $26 billion of loss in work and disability. Many people think that women babies are likely to die while they are in the delivery room, but it's actually untrue. Women and their babies actually most likely to die within a day or a year postpartumly, or just in the perinatal stage. That is when they are away from medical care, away from the eyes and ears of the providers, and probably outside of their health system. So you ask yourself, why is all this happening? Well, some of it has to do with the burnout of OBGYN and the experience of the profession itself. We've seen about 65% of our OBs leaving the practices. It's an unprecedented shortage, which we know will increase. Also increase in maternal desert and lack of access of care. With about 1,500 counties in the United States, whereas there's no OBs and maternity wards are closing on the daily, the shortage in this maternity shortage and the inability to get appointment actually leave moms exposed to further risk, reduction of support, advice, education, and monitoring that ultimately ends up in the kind of outcomes that we are seeing. And by the way, increases in a circle the OBGYN experience as providers. This is where we come in. Baby Live Advice provide the virtual care support, education, and monitoring to close the care gaps in maternity care. We actually provide the 360 degrees care, if you may, wrap around mama by supporting the physician and the health providers as well. We provide all of the services that were traditionally were in our healthcare system, and unfortunately were kept up. Lactation support, social care and coordination, nutritional support, diabetic education. We do virtual group education and classes. We do mental health support groups. We telemonitor patients, and we provide doula and midwifery advice. We do all that from preconception to early childhood. Our platform is a plug and play. It's a tech-enabled service. We are working with our own EMR with a SaaS platform, telemonitoring dashboard that allows us to function in 250 languages. We are extension of the healthcare team, if you may think of so. And so they don't have to invest in any IT themselves, and they don't have to monitor their own patients. We are an extension to support all of the services that put the patient as well as the provider at risk. We are doing this from preconception to early childhood, and we can do it over the phone, chat, group setting, as well as an application and web RTC when women can just put Baby Live Advice.vc.me to see our providers. Benefit of using Baby Live Advice are multiple. They are increasing from economic, operational, and strategic. Obviously, reducing the patient risk and complication reduces their overall cost by reducing ER utilization, readmission, and surgical intervention. On the operational side, by reducing the physician burnout and workload, we increases their capacity to care for women. On the strategic, women obviously makes differentiation for a system to have something like this. It helps them to care better for the patient and improve their outcomes. Proven results, and yes, we do have them. We started actually doing pilots in 2014, and since then also start caring for patients. In total of 1,500 and 500 patients, we saw reduction in C-section, readmission, depression, and improvement in breastfeeding. We actually recently start showing some real reduction in NICU admission and preterm births. And obviously our satisfaction is very big between providers, insurers, and our partners, but the most by our parents. We have many customers and partners already. We are working with Emory Hospital in Georgia, with Huntington Hospital in Pasadena, Citrus Family Cares and FQHC, and Ultimate, the largest FQHC in the United States. We are part of the 1501 Health Accelerator, the preferred provider for the March of Dimes. We are the winner of the Johnson & Johnson Health Innovation Award in Nursing Pitch, and working with HRSA and other providers to get to our patients and get to our mothers, let them know that we're here and we're here to support them. Our business model is simple. We are working with employers, MSO, IPAs, and FQHCs, care organization, and consumers. And the different business models are shown on the bottom. Currently, most of our capacity and most of our focus is on the MSO, IPA, FQHC, and care organization, with a future look into employers and customers as our next, as we get funded and bigger. We are growing. We are actually in profit since 2019, where we served 5,000 patients. To today, we've seen a 6-fold increase in what Baby Live Advice capacity as well as patients. We also increased our provider pool from 15 to currently of 55, and are expecting to close this year in just about $850,000 in profits.
So I'm going to pause you there because that is 7 minutes.
Thank you so much.
Thank you. And judges, you have 8 minutes for Q&A.
Thank you for the nice presentation. I'm curious if you could speak to state requirements vis-a-vis telemedicine and how you handle that.
So we're currently definitely working in more of the states that are, I would say, allowing telemedicine. But in fact, through COVID, obviously, many of those barriers were removed, and some of them will be removed even for up to 2023. So for those states, we are providing care under the telehealth recognition. Truly, actually, you know, since we're working with providers and hospitals, we are less bounded by the telemedicine law because we are not providing medical care. We are only doing education, support, and advice, which can go across state line and is not so limited in the care that we can provide.
Hey, thanks for the presentation. Curious, you said that you're running your own EMR. So I'm curious how you then share information with providers, right? Is that just another portal that the provider would then have to sign into? And have you done any integrations with other health systems?
So God forbid, right, that we want a physician to get to another place. So we share information via integration. We have an HTL7, or we use in Redox to do integration. We are integrated with Epic and the 5 largest: Cerner, Epic, Allscripts, and others. If we don't have an integration, or the FQHC or the providers don't have their own EMRs, then they can have a single sign-on into our health system to see our SOAP notes and what we have provided.
Hey there, Troy Thibodeau here. Great presentation. My wife would have bought this 25 years ago, I promise you. With that in mind, I wonder, do you have, you know, as far as your business approach, I didn't see a direct to mom approach. So is that an idea y'all tried and it didn't work?
Oh, no, it is there, as you can see it. Absolutely. What I'm saying right now, due to funding, actually, we're not spending most of our time or our money direct to consumer, although we are getting them constantly through referrals. So moms who have had us through their hospital system or through their providers will usually talk to their friends and say, oh my God, I'm using Baby Live Advice. So we do have that. The visit is $35 for a 30-minute visit and a $60 for an hour visit. And we do have a direct to consumer utilization. We are just not spending a lot of money in advertising right now, as we're trying to be more concentrating on working with providers and hospitals.
Thank you.
And I would have bought it myself 22 years ago when I had my son, by the way. So I know what you're saying.
A quick question. First of all, thank you for your presentation. Very, very useful, very much needed. I wondered if you could clarify for me the statement about not providing care, but also what does the telemonitoring entail? If you could just.
Yeah, absolutely. So we don't provide medical care. We leave the medical care to the providers, right? And that's where it should be. For telemonitoring, a providers group that we are working with can order a blood pressure cuff or blood sugar or a scale for a mom, and that will be connected to our platform. And we will be the one receiving the data, only escalating emergencies to the provider versus having to have the providers, you know, siphon through all that data. It's also when the blood pressure is high or the blood sugar is high, we can immediately initiate a chat or a call with the mom to say, seem like your blood pressure is really high today. What seems to be going on? So we actually actionable on it to say, what is going on? And, you know, we maybe hear, oh, I just had a pickle. I just had a fight with my, significant other. Or for a mom with high sugar, I just had a little bit of ice cream. We don't escalate everything. We escalate those that need it. So that helps a lot for the provider to keep their eyes on their moms and babies without them having themselves do this job.
Are there any other questions?
Anna, there are hands up.
A lot of hands up.
I have a question. That was wonderful, by the way, as a
Thank you.
OBGYN who burned out from obstetrics almost 9 years ago. I would have greatly appreciated a service like this for my patients. My question is, how does the physicians or the providers get notified that there is an issue? Is that through an advice nurse that calls the physician? Are they sent to labor and delivery? What is the notification process like, and where does the risk transfer from responsibility in case of something going south with malpractice? Is Baby Live advice, are they on the hook, or is the supervising obstetrician of record?
So great question. And all of this has been addressed, as you can imagine. First of all, we hold a massive malpractice insurance. We are an external provider group. So if you think about it from the provider point of view, if you send a mom to a diabetic educator, a lactation consultant, or any other way, you know, there may not be people that are affiliated directly with you. And since we are not doing anything within the medical care, the risk still lies with you. But we are sharing in that risk and making sure that we are supporting you completely, so your risk is actually reduced because we have an eyes and ears on your moms and babies. Notification are being sent through a chat that is we have escalation plans, but for most of our providers, it's with a chat or a text that goes directly to the provider or to whoever is on call. If it's a real emergency and the mom is in real need and no provider is available, if that's the escalation plan, the mom will end up in the hospital if that's what the provider tells us to do. We have directors and I would say coordinators, or this is their job, is to escalate to the provider groups according to the escalation plans that has been pre-placed in place. So again, just think about it as an ancillary services, all of the ancillary services that are being provided just by an external group that is telehealth enabled, but otherwise actually just supporting you, right? If you as a provider, if you needed to have what we have, you will have 15 other nurses working for you in your clinic, which we know that providers cannot afford. Does that help? Did I answer the question?
Yes, but I do wonder, with as onboarding more and more groups of providers, are those escalation plans then individualized?
Yes, we definitely we have to stay individualized, but we have, as I said, we have levels of supervisory support so that to help the nurses to always escalate higher. By the way, just to let you know, in 4 years, we escalated only 1% of our 21,000 cases.
That's great.
Yeah.
Very good. Thank you.
Awesome. That's about all the time that we have for questions.
Thank you.
See, there was a question from David in the chat if you want to answer it there.
Sure.
And then we'll take a quick minute break. Judges, if you can complete your scoring and send that in.
I don't know. I'll stop sharing. There it is. Sorry. Thank you, guys.
All right, we're going to move right along. Next up, we have Martina Janikova with Lara Health.
Can you see my screen?
Yes, you're good.
And you hear me? Great. Thank you so much. Hello, everybody. My name is Martina Janikova. I'm the CEO and founder of Lara Health, and we are building a turnkey care delivery platform designed to optimize patient care at scale while unlocking additional significant revenue streams for medical practices. Doctors today are working harder than ever before, with more patient appointments a day and growing admin burden. There are new care models and tools that allow doctors to work more efficiently, but most solutions live in silos, which makes it really hard for practices to adopt. Lara Health is fixing that. We've built a turnkey platform that takes all the individual care modules and tools like remote patient monitoring and digital therapeutics, and we put them onto one platform, all nicely connected, talking to each other, which makes it easier to implement into existing workflows. And also integrate them into the tools that doctors are already using, like electronic health records system and practice management tools. We don't stop there. We leverage automation and artificial intelligence to make our platform smart and super efficient. Our automation module for patient data analysis drive actionable insights because we know that doctors don't want a flood of unsorted, unmanageable data. Our care workflow automation makes working with our platform simpler and easier. With the recent reports that more than 500,000 healthcare workers left the industry since the pandemic started, we feel it's really important that any level of clinical care staff can actually work with our platform. So this way, even the medical assistant can provide a high quality of care to patients, freeing up the doctor for higher risk patients. Driving patient engagements is difficult at scale. We believe technology fits here really well, and we've built it as a part of our platform. But we are told that our reimbursement automation billing engine is the real golden goose here. Because we put all these different care modules onto one platform, we open so many different revenue streams to the doctors. We currently support close to 40 different CPT codes. That makes reimbursements and billing very complex. With our reimbursement automation module, we make sure that doctors get paid what they deserve to be paid in an easy way. There is a lot of money at stake. If you take just one of the modules that we work with on our platform, remote patient monitoring, by enrolling a few hundred patients onto a remote patient monitoring program, a doctor could easily add $500,000 in additional reimbursements. And so it's really important that they use a platform that's easy to use, that is efficient, and also get them paid without leaving money on the table. We are building from experience. I spent the past 10 years in the digital health sector. I launched one of the first remote patient monitoring platforms out there 5 years ago. And I also had a unique experience in building and testing patient engagement programs at scale. My co-founder, Kevin, is a very experienced software engineer. He spent the past 7 years building some of the most sophisticated automation tools in the financial sector. We also have a great team of advisors, not just on the strategy level. We have a doctor who works with us to ensure that we are building the right product for doctors, and David Zetter, who is the national expert on reimbursement and revenue cycle management matters. Our competitors we are competing with all the individual modules that we put and stack on our platform, but the benefit of working with us is clear. This is an example of remote patient monitoring, a single care vendors that we see out there. But with Lara Health, instead of a medical practice picking individual care modules and digital tools that don't speak to each other, they get all-in-one integrated platform that can easily plug into the EHR or revenue cycle management tool. And with one implementation, they unlock over 30 different CPT codes as part of the reimbursements. And it's much more easier to overlay with automation and artificial intelligence to drive better patient health outcomes, better patient user experience. And as I mentioned, we do have experience both on the clinical side, but also patient side, having digital therapeutics as part of our program. We are a young company. We soft launched only in January this year, but have been growing 20% month on month. We have recently hit 10,000 in monthly recurring revenue mark, and we've seen so far 0 churn amongst our customers. We are a B2B subscription model platform. Our customers are medical practices. They pay us a monthly fee based on the number of patients they have enrolled into Lara Health. And our first sector, we are targeting our independent primary care providers, but we already see a natural interest from specialists like cardiologists, nephrologists coming on board. We have very ambitious plan in terms of scaling our sales, and we are leveraging distribution partnerships and sales alliances to get us there. We've just signed our first significant distribution partnership that will allow us to access 2,700 practitioners in our desired segment, and we are finalizing a second partnership similar in nature, but in a much larger scale. We are currently raising a $2 million seed round to be able to deliver on our ambitious plan. That's Lara Health. Thank you so much.
Awesome. Thank you, Martina. Judges, you have 8 minutes for questions.
Hi.
Well,
Martina, thanks so much for the presentation. Really interesting to see this. Can you talk a little bit about your onboarding and how long it takes practices to spin up with your solution?
It's actually super quick. So as I said, automation is a key, and we make it very easy for them to get started. It's really a matter of shipping them devices for their patients for remote patient monitoring, if that's what they are starting, which they usually do, and training them. We build a platform that's super easy to learn, and it's intuitive. It usually takes us an hour to train their staff compared to weeks and months of training them on their EHR. So it's very quick.
Tom, go ahead.
Yeah, I was going to ask, comparatively, it looks like everybody has these 4 CPTs, and then you guys expand to 30. Off the top of your head, can you tell me what the 4 normal ones are that everybody has, and then what group the 30 are really in that you guys are value add to?
Okay, so the main codes for the remote patient monitoring, do you want the numbers, or can I just explain what they do?
Just explain them.
Okay, so there are some time-based codes. So in general, doctors get paid for every 20 minutes of non-face-to-face care that they provide. There is a code that pays for providing the devices and paying for the software that allows them to access the data, that pays monthly basis. There is some reimbursement for helping the patient to set up the devices. So those are the main 4 CPT codes. Why we support more CPT codes is just because we add additional care modules. So we have CPT codes that cover chronic care management. There are, I believe, 6 of them. We cover additional CPT codes through specialist consultations. We are just currently testing a specialty, a care triage, which will allow primary care providers to provide some of the specialist-led procedures, which they could do if they had the data that Lara Health provides them. So for example, we are starting with a cardiology module that allows them to, for example, triage some patients for, let's say, ECG testing and run ECG patch test. And there is additional reimbursements for that. So it's just stacking all the individual modules together.
David Finn.
Yes, thank you, Martina. I appreciate the presentation. I wanted to ask what you're using artificial intelligence for. What functions or what roles is it replacing?
So we are mostly working with independent medical practices, and you can imagine they all have their own individual workflows. So there is a use case where we are able to create these a care workflows personalized to their habits. The artificial intelligence is used for engaging the patients. So we are able to deliver a messaging or nudges or personalized care based on their preferences or past behavior. And we're also going to implement it into our billing engine, because obviously the industry is known for high claim denials, etc. So being able to kind of improve on reimbursement success, that's one of those areas we'll be using AI as well.
So it's highly structured and specific to the use case. You're not using it in care or clinical decision making.
No.
Thank you for the presentation. I was curious about your target market being the independent physician organizations. Could you speak a little bit about that versus maybe larger targets?
So why we pick the independent medical practices as a starting point, a few benefits. First of all, half of primary care providers are independent. And it just happened that 2 years ago, these new reimbursements came in place for chronic care management, for remote patient monitoring, and created a new incentive for these independent medical practices that get paid for service to jump on board. And it's a pretty much a blank canvas. I mean, we've looked at recent reports. It suggests that during 2019 and 2020, only about 85,000 enrollment claims were filed. You know, there are over 60 million Medicare patients alone, not even counting the commercially insured patients that qualify. I mean, we do have a roadmap down the road to expand to a larger hospitals, but we also feel it's a crowded place. They've been using remote patient monitoring and all these virtual tools much earlier than the independent sector. And obviously there is a room to grow. I mentioned we already started seeing customers from the cardiology, from the nephrology, endocrinology sectors. So plenty of potential clients there.
Martina, does this integrate in with electronic health records?
Yes, so we are slowly integrating with electronic health records, and this is frankly how we are actually also building some of the partnerships on the back of these integrations.
Can you tell us which EMRs you have integrations already built for?
Athena Health, we are building two, which we haven't announced, and we are planning for Epic through a new customer as well.
And one more question: do the patients have an app as well? Is this app based for the patients?
They could. However, we have lots of older patients who are completely non-techie. So we also cater to those. So for example, for a remote patient monitoring platform, they have a choice of having an app and a choice of having a Bluetooth connected device. But we also have devices who work without the tablet, without a smartphone, because a lot of our patients frankly don't have those.
Awesome. That brings us to time. So this worked out perfectly. Thank you, judges. Thank you, Martina.
Thank you.
We're going to take that quick minute break here so you guys can finish your scoring, and we'll reset for the next presenter. All right, next up we have Caitlin Christine with Gabby.
Okay, great. I'm going to assume yes. So hi there, my name is Caitlin Christine, and I'm the CEO and founder at Gabby. In 2013, I lost my mom due to a delayed diagnosis of breast cancer. Shortly after she passed, I found a lump. I had to get physicians to take my symptoms seriously, advocating for myself and my own research. I chose to have what was intended to be a preventative double mastectomy, only to be diagnosed with breast cancer in surgery.
Caitlin, I don't think we can see your screen right now. I'm not sure if it's
working as a hereditary. Oh, shoot. Okay, thank you.
The sound quality is not good either. You're cutting in and out on us.
Shoot. Okay. I don't know what to do. You see it all now?
Yeah, we can see your screen now.
Okay. Let me know if you have greater trouble. Okay. Can you still see my screen?
Yes.
Great. Okay. Working as a hereditary cancer specialist, leading business development for the largest genetic testing company in the world, Myriad Genetics, I began witnessing what my mom and I experienced every day. We realized that my mom and I were not unique. In fact, I was witnessing every day women who didn't know their risks. They didn't know what their options were, and I knew there had to be a better way. In honor of my mom, Lisa Gabrielle, I started Gabby. At Gabby, we're on a mission to save women's lives by decreasing delayed diagnosis. We believe that every woman should know her risks and know her options so she can take action. Though breast cancer is most common in women over 50, there's still a significant portion of women being diagnosed with breast cancer under 50. In fact, 26% of women with breast cancer are under 50. This is often the most deadly diagnosis for this specific demographic because 85% of those women are not diagnosed until late, when the disease is most life-threatening and costly. This delay in diagnosis for women no effective tools. Here's what this pathway looks like for a woman to get a diagnosis today.
Caitlin, we're still having some audio problems, and I don't think your slides
it takes a lot of time.
Caitlin, you may consider turning your video off. That may help decrease some of the load and see if your audio improves and your slides move.
See. Deck.
Yeah, now I think we're on the slide that you were speaking to.
Okay. Already.
Do we want to let her start again just to give her a good opportunity to pitch? She's got a great story, and it's too bad to have these technical difficulties disrupt it.
I was going to ask Aisha, how do we feel like we have the group coming up? Maybe we could flip flop, allow her to log off, log back in, maybe get some of that settled. Is there an opportunity to maybe switch two of the companies their slots?
Yes, why don't we let Futures thrive, move forward, and we'll come back and pick up Caitlin at the very end. How about that?
Sounds great. So
okay.
Wendy, you're up.
Let me unmute, share my screen, give Caitlin a chance to regroup. We want everyone to be fair. Okay. Right. Hi, my name is Wendy Ward. I really appreciate being here today. About 10 years ago, my husband and I suffered the consequences of a child with an undiagnosed mental health condition. We found out the hard way what that means for a family. I've created Future Strive to identify and track pediatric mental health easily, early, and often. Oops. And can everyone see my screen? Okay. Millions of awareness campaign dollars later, the statistics haven't changed. 1 in 5 children still suffer from a diagnosable mental health condition. Half of those will have signs and symptoms long before the age of 14. Suicide is the second leading cause of death, ages 10 to 24, and in certain subsets, that can be worse. The annual Well Child visit is the place that all parents go for everything prevention and early intervention. Height, weight, hearing, vision, scoliosis, immunizations, but not mental health screening. In fact, mental health screenings that do exist today look like this: paper and pencil. They don't start before the age of 12. They have one-dimensional scales of often, sometimes never, and they're inconsistently practiced at best. Future Strive is presenting a new way, a clinically backed, multi-dimensional screener that tracks kids over time as early as the age of 4. It's easy to use because it's web-based for the doctor and game-based and engaging for the kids. Decades of research show that the better outcomes and substantially reducing the cost of care begin at early intervention. 21st century screening for 21st century children can look like this. The child enters a portal. They pick a character and an animal, and they go into one of 4 adventure worlds in which they give us scaled information, context information, family, environment, and school information. But it's not just about having an objective screener. It's about arming doctors with protocols and pathways to help determine what the next step in care should look like, and in turn, taking that to the families and connecting kids to care, because connecting kids to care is what's going to change those statistics 10 years from now. At $3.33 a screener, it's affordable. The American Academy of Pediatrics reports that each pediatrician will have on average 1,500 patients and do over 900 well child visits annually. The lowest Medicare reimbursement state is Michigan at $2.97 each screening, but the average is $4.89, and the average private reimbursement is $10 per kid per screening. The market opportunity for pediatricians is $200 million annually, and for schools K through 12, $500 million to $1 billion. There are easy extensions into universities, colleges, healthcare, and hospitals, healthcare clinics. The projected revenue is just what you see. It's software licensing, but pediatricians and schools don't have to have training in order to enter their profession for the mental health end of it. So training and onboarding and consulting is going to be equally as important. You might think that this is already being done. There's so much going on in the press and panic on mental health, and there's a lot of really good work being done. But I'd like to call attention to the fact that these companies are out there solving the access to care problem. Access to care without assessment isn't leading to accurate care. So Future Strive is putting forward, we need to screen kids early and often in order to get to accurate care. I have 25 years plus sales experience, and I became a concerned mom through my own journey. And I founded a nonprofit for moms just like myself, dads too. But I realized we don't know what we don't know. So in doing the research and launching Future Strive, we began customer discovery at a unique time in history during a pandemic, when we could have key, relationship established through Zoom and over the phone, and we took advantage of it. We completed prototype design with a partner. We did incubators. We're in another tech incubator. We started protocol work, validation work, IP. We are on track to have a data collecting tool December of this year with the right next partner. The tech and data evolution are fairly simple. We can start this year with the MVP design, which moves us into version 1, which means wider range of ages, more data validation, and then into schools first quarter of next year. All of this leaning toward hospitals, clinics, and eventually healthcare providers, insurers. We also have a unique opportunity with the National Science Foundation that is looking to partner with us at the end of this year for design phase 2 of our work. The use of funds is pretty simple right now. We have 3 core areas of work. First is coding. Second is the data development psychometric work. And the other is the game design, which is the engagement end of it. With $350,000 in partnership investments, we can get to that goal of pilots in December of this year. We have garnered 125,000 of that so far. So who are these partnerships and what does this unleash? Well, $100,000 came in partnership with Connecticut Innovations. And we are in conversations with all of these groups, Mental Health America, United Healthcare. One of my mentor partners for this program was Texas Children's, which was really wonderful. You know, we'd like to have a data collecting product to go back to them, but we are also working with the Michael Phelps Kids Camps Foundation, Connecticut Children's here, which is a pediatric provider here in Connecticut. And all of this work puts us in the better position for the National Science Foundation application that we applied for, and they've given us the verbal approval to move forward on. We got here on a lean and mean model. This is what this projected revenue looks like. It's lean and mean. We can start with revenue this year 2022, at $68,000 to $70,000, and by year 5, we get to near 14 million. This is lean and mean. With the right partners and additional funding, this revenue ramp can change for the better.
Wendy, I'm going to stop you there because that is 7 minutes. Thank you so much. Judges, you have 8 minutes for Q&A.
Thanks for a great presentation. I'd love to know a little bit more about the market dynamics that you're going after schools before healthcare providers, and I'm curious why. What is it about adoption that you think will be more straightforward in schools as the next target?
So that's a great question. The reality of it is pediatricians in schools are sort of a community connector. So I looked at it, I think one of the compelling parts of this work is I've looked at it from a mom back to the healthcare system and back to the school system. And how can you reach the mom like me who thought she knew, but then realized she didn't know? And so what I did is I turned it all upside down and said, well, if you're working with the doctor, likely if a problem comes up, that's showing up in school. And these two community sectors work together really nicely. The other thing is, again, you go back to that connection to care. Schools are set up to connect to care through the tier 1, tier 2, and tier 3 model that exists within a school. They do screening all the time, and we all know they're suffering with mental health issues. So it's a different delivery with the pediatrician versus with the school, but both of those deliveries have the equal outcome of the child that needs help in the mild and the moderate gets help.
Thank you.
Hi, as a child psychiatrist, I think it's great that you're trying to attack this issue. I'm very interested in the technology. You talk about comparing your technology to the pencil and paper, usually parent completed scoring. What evidence do you have that something that the child does is better than the kind of what people do now? It's not always done by pediatrician offices. They'll pencil and paper by a parent, that a child's version is better at expressing their feelings, especially since a lot of kids, especially at the young age, have a hard time expressing those emotions or knowing that their problems are even problems.
Yeah, so that's a really great question. And the reality of it is that kids don't talk the same way adults do. And I think that's something that I super identify with. So using technology makes that a little bit easier. One is our prototype is ages 9 to 14. That tween years, they still really, really want to tell you everything that's on their mind, and they might not verbalize it the way in which an adult can identify it into anxiety or depression or any other mental health issue. So what we've done is we've created a methodology of questioning based on clinical work that's already been done. So the question says, on a scale of 1 to 5, 5 being the happiest, how happy are you overall? And then it goes into what makes you happy. And the child knows the answer to that. It might be my teddy bear makes me happy. It might be not going to school makes me happy. It might be baseball makes me happy. But we can figure out from the context behind it. So all the questions are asked within that context of, if there were one thing to make you happier, we follow up on that. What's the one thing that could make you happier? We have AI that runs on the back end that does keyword flagging to give the practitioner or the school the answers to that. They start to show on the Likert scale signs and symptoms of anxiety, then we give them the context behind those questions and scales. Does that make sense?
Thank you.
And I kind of have a follow on to that, Wendy. The two biggest issues we find in healthcare with artificial intelligence is the cognitive bias that gets built into the algorithms that people write. And we've also understand that the data is valuable, but only if you have a volume of enough diverse data to begin to leverage it. We also know that sentiment analysis, particularly from text, can be fairly easily manipulated, even by kids. So what kind of controls or what kind of mitigation have you built into the system to address those issues?
So great question. And our data is going to evolve. So what we did is we started out with what's an informative result that's actionable that we can give to the practitioner or the school today. So today, what the results form looks like is signs and symptoms based on the Likert scales, and then the context behind it without any kind of interpretation on the back end. So it's just, how can we inform the doctor the most amount possible? So we ask family information. Who do they live with? Have they had a death in the family? Do they feel all risk and protective factors that are measured and clinically backed today? We didn't invent anything new. The sentiment analysis that we have running on it will literally be trained. So right now it's going to serve no answers. You won't get it on the result. But a year from now, when it's trained properly on thousands and thousands of kids, it'll start to render a result. We sort of built in that we could evolve and change and grow to make sure that we weren't operating on the usual biases.
Thank you.
And this is Dr. Karen Hill as a follow-up to David's question. As you are putting more children into your system, in a sense, as you grow the number who have used it, how are you assuring that you are getting ethnic diversity? Because that's going to be an issue. You know, your algorithms, as they are trained, you're going to have to assure that you're measuring that and following the differences with ethnic preferences.
So I will tell you, that is the top of all the work that I do, is that as a parent, and again, coming from the perspective of the person with the kids that wants them to be healthy and go out and be healthy producers in the world, it doesn't matter to me if we get this into 10 neighborhoods that can afford it. So we priced it accordingly. We're looking at pilot partners that are diverse right out of the gate. We are trying to bring on more advisors and partners that bring that into balance. And we built it into our National Science Foundation grant that we would, in fact, do research on biases specifically and the way we run our algorithms. I think I can tell you right now that I'm dedicated to making sure we don't just have another tool that people can afford, that we have a tool that spans far and wide and helps in appropriate areas of the country in appropriate ways.
Thank you.
Dr. Newhouse, we have time for one more question, so go ahead.
Mine's a quick question. Does your roadmap include bringing in telehealth services for the pediatric population?
So it's always been on the table, absolutely. It's also a great exit plan if you look at the electronic medical records or the telehealth companies. That being said, we expect to need to partner in various places, because if they buy the pedagogy of the app, we also want them to buy the pedagogy of immediate care. So one of the big breakdowns are, here's my three, as a doctor, here are my 3 cards, go to these practitioners. None of them take insurance, 2 of them are busy, and good luck to you, parent. We'd like to have a softer exit. You walk out of the office and you can make an appointment with somebody who's connected to that practice or connected within that school. So I fully expect that that's going to be a hybrid model of actual practitioner and telehealth companies.
Awesome. Thank you, Wendy. Thank you, judges. We're going to take a 3-minute break this time. Aisha, I believe you're coming back on for a quick segment.
I think I'm back here. Okay.
Yeah, there you go.
Navigating the technology. I hope you've enjoyed the first 3 pitches, and you have a little bit of an example of one of the pitches yet to be heard. I think we've had a great presentation so far. I wanted to take this opportunity to just recognize the partnership that we have really appreciated with the Texas Medical Center's innovation team. Since the inception of Ignite, and this idea of first what started as a pitch event and has now turned into a mini accelerator program, the TMC has been by our side. We've always hosted the events in person, the pitch events in their facilities. They've welcomed us and really made available the resources so that we've been able to learn by their side how to source really great companies and how to host a program, how to put together a mini accelerator. So we're grateful for the support. You see the support because it is a part of the experience you have today with Megan Howard, who has been shepherding this whole process along and worked with us extensively, with Anna Vu, who is moderator for this session. You don't see Emily Reiser, but Emily has spent hours with us and has been an important part of our committee and helping us to get here today. You also don't see Tom Luby, but you will on I keep saying November, on January 20th, when we have the in-person grand finale. Tom is the director of the Innovation Institute. He's served as a judge for our grand finale programs for the last 3 or 4 years and is a great supporter of Ignites. They give programs, they give prizes to our winners and have just been truly the wind beneath our wings. So we want to just share a little video with you to give you an example of the magnitude of what is the TMC and the possibilities for startups to come into the Houston community and collaborate with the various partnerships that are located here. So with that, I'll turn it to Megan. I think you will you cue the video? Thank you.
Some of the greatest devices in the world, some of the greatest new therapies were all born on this campus. 1,500 acres, completely densified with 21 hospitals, medical clinics, research building. Every piece of real estate is dedicated to advancing health, education, and research.
What do we have that Silicon Valley doesn't have? The Texas Medical Center. That's what's going to make this place succeed.
So you take this platform, this Texas Medical City, and imagine what you could do to create an environment for startup companies.
The Innovation Institute is the building in which all of the pieces of Texas Medical Center's innovation program sits. TMC Innovation consists of this whole suite of resources.
They really do have a program for every stage of company, and you really don't see that anywhere else.
You can do everything here. You can do a clinical pilot here. You can innovate your idea. You can find engineers. You can figure out the business aspects of your company. In one building, in about 300,000 square feet, you can find all of that. A place like you're not going to find anywhere else in the world.
Here, there's an ecosystem. There are people who understand what it takes to turn an idea into a real product.
It can be formidable, and ideas die because people are afraid. It's a place that keeps ideas alive.
All right, Aisha, back to you.
All right, thank you. I think we have some, I don't know how you all saw that video. We may have some choppiness there, but if you join us on January 20th, you'll see a tribute and a true thanks to our partners at the TMC. They are an incredible resource, and we're grateful for all of their support. So with that, I'm going to turn it back to Anna and to continue the 3 remaining pitches. Anna?
Awesome. Thanks, Aisha. I'm biased, but I'm also a big fan of TMC Innovation. So we're going to move on. Caitlin, I believe you're back. Let's try your pitch again.
Yes. Awesome. Thank you so much, everyone, for your patience, and my apologies. Okay. Are you seeing the deck?
Yes, this is good.
Amazing. Okay. So please, hopefully, I know this is now the second time you're hearing this. Please listen to it with a new ear and hopefully with better connectivity here. So my name is Caitlin Christine. I'm the CEO and founder at Gabby. I lost my mom to breast cancer due to a delayed diagnosis in 2013. Shortly after she passed, I found a lump, and I had to fight to get physicians to take my symptoms seriously. After almost a year of speaking with experts, advocating for myself, and my own research, I chose to have what was intended to be a preventative double mastectomy, only to be diagnosed with breast cancer in surgery at age 24. Working as a hereditary cancer specialist, leading business development for the largest genetic testing company in the world, Myriad Genetics, I began experiencing and witnessing what both my mom and I experienced. We were not unique. I witnessed every day women who didn't know their risks, didn't know what their options were, and I knew there had to be a better way. In honor of my mom, Lisa Gabrielle, I started Gabby. We're on a mission to save women's lives by decreasing delayed diagnosis. We believe every woman should know her risks and know her options so that she can take action. Although breast cancer is most common in women over 50, there's still a significant portion of women being diagnosed with breast cancer under 50. In fact, 26% of women with breast cancer are under 50. This is often the most deadly diagnosis for this age demographic because 85% of those women are not diagnosed until late stages, when the disease is most life-threatening and most costly. This delay in diagnosis for women under 50 occurs for a myriad of reasons. But first and foremost, there are no effective breast cancer screening tools for women of this age. Here's what that pathway looks like for a woman to get a diagnosis today. With Gabby, we're able to identify the women at risk, decrease the time to a diagnosis, improve health outcomes, and ultimately save lives and money for the plan and the individual. When you take into account COVID, we have an even greater opportunity. The total spend on delayed diagnosis of breast cancer is $974 billion. We see our total addressable market is $812 billion, which comprises all women covered by commercial insurance, and our serviceable addressable market as those who are insured through their self-funded employers. We solve this problem of delayed diagnosis with our twofold solution. First, identifying women at risk utilizing artificial intelligence by incorporating claims, EHR data, and patient-reported data. And second, we compel women to take action through personalized action plans, community support and accountability, and a human-centered design mobile application. We validated our risk model with a national payer earlier this year, showing that our accuracy far exceeds existing models. To put this in perspective, this national payer had 16,000 women diagnosed with breast cancer in 1 year. Of those, almost 13,000 were diagnosed at late stages. Had they been using Gabby, however, 75% more women would have been diagnosed at earlier stages, when this disease is most treatable and less costly, saving over 5,000 lives and over $400 million. For example, we found Mira. Had this payer and Mira been using Gabby, we would have identified Mira at stage 1. But unfortunately, she was diagnosed at stage 4 in 2018. We're able to accomplish this because we're filling the 3 holes that exist in current risk models today. First, inclusivity. Existing risk models are only appropriate for white women over 35. Gabby is appropriate for women of all ages and all ethnicities. Second, accuracy. Existing risk models at best are 63% accurate, and we have an 85% AUC. Third, approach. The existing risk models are only used in clinical settings where only 5% of clinicians actually run their female patients through these risk models. Gabby is the first ever consumer-facing risk model. To date, we have raised an oversubscribed pre-seed round of funding, validated our risk model with a national payer pilot, and won Accenture's Rising Star Health Innovation Award of the Year. We're going to market first with self-insured employers like L'Oreal or Bank of America, selling with an implementation fee and a per member per month. Once we've proven product market fit, we intend to roll out to payers, and eventually, once we own both of those markets, we have a direct consumer play. Our competitors include Volpara Health and CRA Health. However, these other organizations are confined to the clinician and to populations that work through clinicians. We are starting with breast cancer, but because our model is generalizable, we plan to expand to other preventable diseases that affect women. We have a dedicated killer team of experts, a couple of which are on this call too, and we are all either female or a person of color. We also have a dedicated team of experts spanning every industry that we will touch, from successful startups like Castlight Health to academic institutions like UCSF and payers such as Anthem. We're solving breast cancer delayed diagnosis and won't stop until we do. So if you're interested in saving lives, please reach out to be part of our solution. Thank you.
Thank you, Caitlin. That was exactly 7 minutes and nicely done. Judges, you have 8 minutes for Q&A.
About this person, yet he definitely introduced you to the consultant who I need to talk to about this role. Understand what is.
Caitlin, this is David Finn. A great presentation and obviously a huge need, but I did have one question because I looked at the pitch deck. I then went to your website and then I saw this deck today. And when I look at the problem described today, I've seen 3 different numbers for the cost and the number of weeks to diagnosis. So I was wondering if you could answer that question for me. Obviously, you have data changes us all the time, get that. But which is the set of numbers? Because I've seen numbers from 150 to 400,000 and from I guess 24 weeks to 104 weeks.
Sure, great question. So what you see on our website means that it's fallen to the bottom of my to-do list in order to update that. So what you saw on the deck is most appropriate. And the way to look at that is that's 104 weeks. And that was the $400,000, which is a 2-year period, essentially like a 2-year period of time. Does that answer your question?
It does. And believe me, I understand the problem with website updates.
Dr. Newhouse, I see your hand up. Go ahead.
Of course you do. A couple of questions for you, Caitlin. Caitlin is, one is, what are your numbers showing for prevention? Are you applying this to women like myself that have the breast cancer mutation? And are you identifying this population before there is even a diagnosis of cancer? And my second question is how is your model, if you can talk about it, different than the GALE or the NCCN? And how did you evolve that model? And what sort of patient population are you validating? Are you retrospectively using data to find this? Or have you actually put this through a large study yet?
Okay, so to answer your first question, which was around, excuse me, prevention. Thank you. Yes, we are purely preventative. We are only appropriate for women who have not had a breast cancer diagnosis. Although we are not predicting who has a genetic mutation, that is part of our workflow for the recommendations once we've assessed your risk. So should you have a specific risk and it involves specific family history, one of the action items is to get genetic testing. So there is an aspect of what we're doing that is funneling more women to get genetic testing. To the second part of your question, so we did do a retrospective analysis with the national payer going into their claims data. To answer the question around how we are different, one, that we're using claims data. Two, that we're appropriate for women of all ages and all ethnicities, which helps. And then three, our accuracy. Four, we're just taking in different inputs separate than any of the risk models that you mentioned. And then of course, lastly, the approach.
And what is your N? Like how many thousands did you look at to come up with this?
Sure, we looked at 14 million women.
That's great. I'm excited by your company.
Thank you. Thank you. It's always fun to speak with clinicians who are very familiar with risk models like the Tara-Cusick and the BCSD, and they get very excited about what we're doing.
Terry, I think I saw your hand next.
Yeah, thanks for a great presentation. I'm curious, your pilot that you did with the national payer had some pretty compelling results. So what's the next step with that payer, and have they indicated interest in furthering a relationship?
Yeah, they have indicated interest. However, as a payer, they typically want a lot more proof points before they implement something and roll it across any of their member populations, which is really when we decided to start selling initially for go-to-market to self-funded employers. So we're tackling that from the self-funded employer side. And by the time that we have a couple of those self-funded customers in our pipeline, then it makes a greater argument for the payer.
Eric?
Great, thanks. Hey, great presentation. Excited about the company. Curious if you could talk a little bit about kind of the design process. I think this is could be a bit of a finicky demographic to go after as far as engaging with not only walking through the process, but the actions to take afterwards. So I'm curious on how you approach that.
Tell me a little bit, can you say more on what you mean by design process?
So the actual, engaging, so within your app, so from the patient's perspective, within your app, kind of how did you, the process that you're doing to not only the front end design piece, but also to keep that fresh as engagement methods change and things like that. Does it make sense?
Sure. Yeah. And great question. Thank you. So I think the first thing is that when we were doing our R&D, we discovered that women really want to know their risks, but they don't have someone to trust. They don't know where to go to get that information. So by getting women to know their actual risk, we're increasing that engagement. We're getting them invested. The second is once they know that there's something they can do about their risks, now they're a lot more invested. And then the third hole is where we come into the longest time that it takes for a woman to, let's say, one of her recommendations is that she needs to start getting biannual breast MRI and mammogram. Well, traditionally, she would have to go to her OBGYN. They would have to agree that this is needed, and then they would put in a referral for that imaging. And then she would have to wait for the imaging center to reach out to her to schedule that appointment, which may or may not need to be done in conjunction with her period. So now we're waiting multiple months here for this to happen. So at this point, when a woman knows her risk, she gets her action plan, she looks at her actions, and there we are positioning ourselves from that point where we'll be a provider. We're able to put in that referral for any of the diagnostics. So now she's able to just go directly to whatever the imaging center is within her area that's covered by her insurance, and we'll be able to receive those results as well and share them with her OBGYN. Does that help answer your question, Eric?
Yep, thank you.
Awesome. And then we have time for one last question. So Troy, go ahead.
Yeah, I think it's along the same lines as far as your process looks like it expedites the diagnostics. And I think somebody already asked you the question around how are you working with payers, but I'm curious, have they been more receptive on kind of lowering the bar as far as their pre-approval and denial process to let those diagnostics occur earlier?
Great question. So that is another reason of why we're going the self-funded employer route, because that now they get to go to their health plan and say, hey, listen, we're doing this thing. You need to let this go through if anything's recommended by Gavi.
Thank you.
Awesome. Thank you so much, Caitlin. We are now going to take that minute break again. So judges, if you want to complete your scoring sheets. All right, we have 2 more to go. So next up we have Kath with Loop Plus.
Fantastic, thank you. I'm Kath Hamilton, and together with my sister Claire Conroy, we're the founders of Loop Plus, based in Australia. I'm now in New York. We're building a more equitable and human-centric care system for 10 million wheelchair users in developed countries. You see, Claire's son, Vander, was born with a tumor pressing on his spine that left him paralyzed. But like many wheelchair users, as well as having no movement below his waist, he doesn't feel pain, the body's natural warning signal. So he has recurring acute health issues, including scoliosis, pneumonia, and pressure sores. Now, you might think a pressure sore is just a bruise. Don't Google it, you cannot unsee that. Because when developed, it's a cavernous hole in the body that renders some bedridden for months, even years. In fact, 60,000 people die each year. And yes, Superman died of a pressure sore. The cost of care each year for wheelchair users in the US outstrips many other conditions in annual and lifetime costs. And you know what the most common cause of hospital admission is? Urinary tract infections. If you can't feel pain, that excruciating pain, it becomes a critical infection pretty quickly. Something so simple to treat if caught early has an average hospital stay of 15 days for this population. So the daily environment is damaging their health, and they can't understand their own body to know when it's happening, which leaves the care team out of the loop. Until now. Loop Plus is a positive feedback loop with wheelchair users and their care team. The proprietary sensor pad is fixed in the chair to continuously measure seated pressure, position, and movement. It learns routines and identifies potential risks based on changes in daily habits and physical activities before they reach a critical stage. Loop Plus is FCC certified and doesn't require FDA listing to commercialize, which basically makes us a Fitbit for your bum. So here's a use case. A key risk for pressure sores is sitting still because it restricts blood flow. And the clinical guideline is shifting weight every hour for 2 minutes, every hour for the rest of your life. Obviously, very few people do that. So we show them the times of day when they are both idle and in a poor position. And the game changer is that the user can replay their pressure distribution as if it's in real time, to understand how they were sitting during a particular activity, to discover that, say, cooking dinner actually relieves pressure, and build activity like that into their routine. So for the first time, wheelchair users who can't feel, or maybe non-verbal with a brain injury or cerebral palsy, have visibility of their body, giving them confidence to make informed choices. And our next stage of development is powering care management that will connect this actionable information into the care pathways for spinal cord injury, multiple sclerosis, cerebral palsy, stroke, and other conditions. For example, the readmission rate for spinal cord injury is 36% in the first year after initial injury, 30% thereafter. That's billions of dollars in additional costs. So Loop Plus will be able to support the transition of care program for, say, Memorial Hermann's. When in hospital, Loop Plus would help the new wheelchair user understand their body. And then when discharged, support them with continuous monitoring to engage them so they can understand and adhere to their discharge plan, educating them with targeted, timely content and connect them to health services. Loop Plus connects the dots, supercharging connected continuous care management and reducing preventable admissions. So it becomes very clear why the market opportunity to contain these preventable costs is so large. The recurring health needs of the 3.6 million wheelchair users in America creates $10 billion of annual revenue opportunity for us. And then narrowing it to just the privately insured, it's still worth $3 billion in sales. Expanding back out to the elderly grows the revenue opportunities to $19 billion each year. This market is huge. In Australia, we're fully reimbursed. Today, it's a classic IoT business model, starting with a fixed price device in the app and then adding services. These are insight reports to inform treatment or seating assessments. These are prescribed on a recurring basis in line with those recurring health needs we've just seen. In America, we've been working with clinics during the last few years of development. Initially, we're direct to consumer. Then in the clinical setting, allied health and wound care providers subscribe to Loop Plus to support both in-person and telehealth treatment. Then those care management programs can power the front door of care for this population, ultimately connecting the full network of services. We've generated over $60,000 in sales in our first few months of beta, mostly in Australia, and have our first distributors onboarding in Australia and New Zealand. Plus, Coloplast will begin screening through their continence clinics there next month. And just last night, Yamaha Motors confirmed they will start market testing our device for distribution in Japan. We've sold to 3 spinal hospitals, including our first in the US, Fraser Rehab in Louisville, without FDA certification required. And we're in discussions with another 9 care providers here, including 2 model spinal systems and a children's hospital that I know will be very close to your hearts. So look, sensor pads have been around for decades. Our patent pending system is unique in using this pressure data to calculate personalized risks for the whole day's routine. It's not just a device. We have decades of experience in commercializing digital consumer products for millions of users in the disability and health sectors and developing sensor and IoT technologies. We have strategic investors who know the commercial value of solving for wheelchair users in Yamaha Motors, who manufacture a power assist wheelchair, and Australian insurer iCare. We've raised over $3 million to bring our Fitbit for Your Bum to market in Australia. Now we're raising a further $6 million to scale it globally and to build out those care management programs for providers. We're creating the world's largest data set of wheelchair seating habits. Programs that use these insights should save billions of dollars in preventable admissions and care each year. And we forecast that within the next 5 years, Loop Plus can return $75 million in annual revenue, with distribution in just Australia, US, Canada, and Japan. I told you this market was huge. And private equity know this. So the global wheelchair manufacturers are each owned by European private equity, with portfolios of billion-dollar health management companies. So the addition of Loop Plus would increase the value of both care services and their physical solutions. A pretty great brick to add to their stack. So today you've heard how Loop Plus will transform Evander's care, transform his life. So I invite you to join us on this journey to impact all wheelchair users, to get that critical knowledge to where it matters most and keep people out of hospital so they can thrive. Thank you.
Thank you very much, Kath. Judges, the floor is yours.
Oh.
Tracy, go ahead.
Thanks so much for the presentation, Kath. I can see how this would be incredibly impactful for, folks like your nephew and then other wheelchair users. Clearly, this is sort of an enormous market. Can you talk a little bit about the platform and its potential extension into clinical use, such as, in beds and things like that, for a more episodic care?
Yeah, it's actually, there is a product, a sensor sheets that do go into beds, and I think they tend to be, and there's also the sensor and other devices that are much more high fidelity pressure mapping systems. What we do is look at what the behavior is of the state of the user, and then manage the risk around that. So it's not just about pressure, but the holistic care. So understanding their routines and the change in that routine. So baselining the routine, and then when there's a change, so such as continence habits, so bladder habits, if they change the amount of times they go to the bathroom, then that is an early indicator of, of perhaps a UTI. And so intervening before there's issues. And so that's the main, that risk identification and targeting care.
Susie, go ahead.
Thanks. Wonderful presentation, and I apologize because I likely missed this. Can you go to the slide that talks about just the funds that you've raised thus far and what you need to bring it to market?
Yep. So we've raised $3 million in US, so 3.4 million in US dollars, and then we're raising another 6 million. So that'll enable us to go global. So we're just building out our operations now. So that's all the distribution, inventory management, that kind of thing to go global. So on that side, and then obviously the building out the application of the data into the care environments. So building it into, say, a transition of care program. So that's using the clinical guidelines and protocols of some of the health systems. So we need to work with them to build that out.
Thank you.
Any other questions from our judging panel?
Great, thank you very much.
All right, thanks, Kath. Judges, you have a minute to submit, and then we will move on to our last pitch of this session. All right, last but not least, we have Tatiana Fofanova with Coda Health.
Okay, fantastic. 1 second. Gonna bring this up. Can y'all see this yet by chance? No.
Not yet.
Okay. Oh, we can fix that. All right, perfect. How about now? Fantastic. Okay, hi everyone. My name is Dr. Tatiana Fofanova. I am the co-founder and CEO of Coda Health, where we take difficult conversations and make them a lot simpler. So most of what we consider to be medicine is actually conversational. You go to the doctor, you talk about your symptoms, your lifestyle, but there are some conversations out there that are a lot harder than others. And that goes for both parties. And for example, do you know what kind of care your loved one would want if they fell seriously ill today? Most people feel confident that they do, but unfortunately, without that conversation being clinically guided, the likelihood that you choose what they would have chosen for themselves is only 50%. And that is personally devastating to families and patients. And most of that burden falls on women, but it's also egregiously expensive. Health systems and payers shell out an estimated $200 billion each year in the delivery of unwanted or inappropriate care. Now, traditionally, planning for future healthcare fell to estate planning attorneys or to those individuals proactive enough to pursue direct-to-consumer solutions. But these approaches tend to ignore the quality of the conversation. They cut doctors out of the process and frankly, they target people who can already afford it. But the oldest and the poorest in our society don't have an estate to plan. They don't have access to these solutions. So we knew that we had to make this an easy, engaging, accessible process for everyone. So we built Coda. Coda is a difficult conversations platform that acts as a single source and solution for both patients and providers. Introduced by the physician, Coda does the conversational heavy lifting. Using motivational interviewing and our proprietary personalized content algorithms, patients are able to explore their values, identify who will speak for them when they can't speak for themselves, navigate quality of life scenarios, explore treatment preferences, and indicate those preferences on our platform. And as they're navigating this, all of their responses are captured to automatically generate the necessary medical and legal documents they need to protect their care. Documents they can edit, access, share, and virtually notarize right then and there on our platform for free. Now, by digitizing this process for physicians, we make it easier for them to introduce to their patients, but we also streamline the billing and documentation components necessary to close the loop on this process, allowing staff resources to be used more effectively. And even though this has been a multi-billion-dollar problem for a very long time, the regulatory environment didn't really exist to support a solution like Coda until quite recently. So with the aging population enrolling in Medicare during a global health crisis, Medicare is pushing out new reimbursements, performance metrics, incentives programs, innovation programs that are specific at bringing this conversation into a clinical setting, leaving a lot of folks caught off guard. So as a B2B company, we help individual fee-for-service providers realize that new line of reimbursement revenue. For risk-bearing systems like accountable care organizations and integrated delivery networks, we help them save on average $10,000 to $15,000 per patient, as well as help them meet those new performance metrics. And lastly, because Medicare is reimbursing for anyone over the age of 65, at our price point, that's an annual revenue opportunity of over $6 billion. Now imagine the potential if this was conducted during enrollment. How many preferences would be chronicled? How many painful conversations could be avoided? So in order to execute on this vision, our HIPAA compliant platform is already live in fee-for-service clinics in 2 states, where we're helping physicians generate a 3x ROI on bringing us in. Our paid pilot with the Houston Methodist ACO has recently, by which I mean last week, converted into a 3-year contract where we're extremely happy and proud to be serving their patients in the long term. And lastly, our time with the United Healthcare Techstars Accelerator has been incredibly fruitful as we've jumped into the vendor approval, security review, and MSA negotiation process in preparation for 2 potential pilots in their organization. Now, really, this is just the beginning. Since incorporating 18 months ago, we've received growing market traction. And with case studies in hand and pilots closed into bona fide commercial agreements, we know our digital approach to difficult conversations works. But most importantly are our patients who have been meaning to get around to this, but haven't due to time or resource constraints, are grateful for being able to stay in control of their healthcare journey. So why is this working so well? Well, frankly, it's important to remember that the standard of care is virtually non-existent. Only 7% of patients have ever spoken to their doctors about this. And existing competitors fall into two buckets: pure SaaS solutions, which are low cost and low labor, but unfortunately focus mostly on documentation and are very easy to abandon by patients. And the other bucket is externalized advanced care planning providers that have dedicated staff to guide patients through this discussion, which is wonderful and personalized and high quality, but extremely high cost and only offered to the sickest portion of the population. At Coda, we want to make advanced care planning accessible to everyone. So we offer personalized experience at SaaS level prices. Now, our team of doctors, scientists, and engineers are backed by nationally recognized organizations. We're featured in prestigious industry publications, but far more importantly, each of us have had hundreds of these conversations with the patients we serve before we ever wrote one line of code. And the support of the Texas Medical Center and the National Science Foundation and health systems across the country has garnered and attracted a star-studded advisory board of industry-leading execs that recognize the cultural shift happening in this space. Our team is growing and we would really love for you to be a part of it. So today, we're looking for for-profit and not-for-profit strategic partners that can help us bring Coda into new markets. We're looking for mission-driven investors that can help us close out our seed round at the end of this month. And I'm excited to use this opportunity to announce that we are hiring for multiple sales and marketing roles. So please reach out. At Coda, we believe that everyone should stay in control of their healthcare journey, and we really hope you'll join us in this mission. Thank you.
Thanks so much, Tatiana. Judges, floor is yours.
How long does it take to complete the start to finish, like for a 78-year-old person to do?
That is a great question. So we spent an enormous amount of time on our UX UI, and we've built this exclusively for a patient that is on average 80 years old. It takes approximately 18 minutes for them to navigate this platform from start to finish on their first go around. If they want to do a notarization or a virtual notary or an e-witnessing, that's also available, whether it's done through scheduling or right then and there.
Is there any time for it to go into effect? Like, is there a waiting period or anything like that, or it's effective immediately?
Upon signature.
Troy, go ahead. Or we can skip to Terry.
Oh, I'm sorry. Were you referring to me? I couldn't hear you. I just had a quick question. Is this is self-guided planning by the patient themselves? It's not actually advanced care planning from a provider working with the patient, correct?
So we wanted to leverage the skill sets of the physician in this process. And in doing so, the patients are able to explore a lot of the educational components on their own in a very standardized and structured way, making sure everything is covered. What normally happens is when this is delivered in a clinical setting or in a clinic or at the hospital, a physician reviews a patient's care preferences and addresses any outstanding concerns and helps them make those final decisions, which is a much better use of their time than describing how a ventilator works 8 times a day, and is far more consistent in that delivery as well.
Thank you.
Mm-hmm.
Thanks, Troy. Terry, over to you now.
Thanks for the presentation. I'm curious, as an investor, what does an exit look like?
That is a great question. So we have 2 general thought processes in mind for that, right? There are those organizations that offer complementary services that we could slot right into for an early stage exit opportunity. That is not our preferred approach. Our preferred approach is to exit to a data-driven payer. At the end of the day, payers are financially responsible for inappropriate care delivery. And the amount of data we're capturing on patient preferences and how that impacts decision-making is very attractive for them. It's the end of a very long day.
All right, do we have any last questions for Tatiana? All right, Tatiana, I think you're good. Thank you so much.
Thank you.
So that's all 6 companies that we had for this session today. So thank you so much to all the companies. You guys are doing incredible work. I'm super excited to see how you guys continue to grow from here. Judges, thank you so much for your time and your thoughtful questions. I think I learned a lot listening to you guys. So thank you so much. Don't forget to fill out your surveys to submit the judging results. And now I'm going to turn it back over to Aisha for some final remarks.
Great. Anna, thank you so much. You did a fabulous job moderating, and we appreciate you taking the time to join us. To the presenters, great pitches. Thank you for all your hard work and for the great pitches this afternoon. I wanted to also say thanks to the judges. We appreciate you taking the time to spend with this program and engage with the great questions for the startups. So thank you for all of that. Just a couple of reminders. Winners from these panels will be announced on Monday the 18th. We will have them on LinkedIn and social media and push it out on Whova. And the winners will move on to the January 20th final competition in person in Houston, Texas, which promises to be great fun and to bring great talent to the floor that evening. I wanted to also make sure that you please complete your scorecards. If you'll do that and make sure you press submit. In the last session, we had somebody complete, but I don't think the submit came through, so we chased after them a bit. Your scores and your comments are really important to us, so thank you for that. And on that note, one final thing is the People's Choice Award. So if you have time to go listen to the other pitches that are being recorded, please do that and vote often. We're not really policing the process. So I'm seeing the votes coming through. Last year's winner was incredible and went on to get investment prizes as well as opportunities to collaborate. So I do think we've got some good companies that come through, and we look forward to seeing who is the People's Choice Award winner. So on that note, I'm going to call it a wrap. Thanks, everyone. I hope you have a great afternoon, and we appreciate your support again this year. Good to see you. Bye.